Welcome to another deep dive. We are so glad you could join us today.
Yeah, thanks for tuning in.
So today's mission is, well, we're unpacking a really highly specific but universally vital clinical procedure. We've been looking through our stack of urological and gynecological sources.
And there's some fascinating stuff in there.
There really is. We are specifically exploring the clinical procedure for placing a Foley catheter in, complex female cases where the anterior wall anatomy is just completely distorted.
Right, like with a cystocele or severe pelvic organ prolapse.
Exactly. And you might be wondering why you should care about something so highly specific. But whether you're a medical professional prepping for a complex case right now, or just a learner who is fascinated by how experts problem solve human anatomy on the fly, this is for you.
Yeah, it really is wild.
It is, because this deep dive is going to reveal how clinicians take a really frustrating, high-risk physical roadblock and, turn it into this aha moment of anatomical realignment.
And to give some context here, placing a catheter is often this absolute necessary first step. You have to do it before you can instill medications or do intravesical therapies.
Right, like Botox injections for an overactive bladder.
Yeah, exactly. You have to secure that line. But when the patient's anatomy doesn't match the textbook, the standard playbook just goes completely out the window.
Hmm?
The procedure requires a completely different tactical approach.
You're essentially flying blind if you just rely on the standard training.
You really are.
Okay, let's unpack this. Before we can even understand the solution, we have to kind of map out the physical obstacles, right?
Right, because the baseline anatomy is usually pretty straightforward.
Yeah, like a standard female urethra is just this relatively short, straight, fibromuscular tube. It's only about 3.5 to 4 centimeters long.
Under ideal conditions, yeah. It offers a very straight, short pathway right to the bladder.
But the sources highlight that conditions like obesity or atrophic vaginitis from menopause, or specifically a cystocele, they drastically change this landscape.
They completely alter the internal geometry.
Right. And, for those who might not know, a cystocele happens when the muscle weakness allows the bladder to essentially fall down into the vaginal vault,
Which effectively distorts the entire anterior vaginal wall.
so why is that so problematic when you're just trying to pass a tube?
Well, this prolapse can actually pinch off the urethra. It causes this severe inferior angulation right at the bladder neck.
So it's bending it downward.
Yes. And it's not just the angle that changes. The external landmarks disappear too.
Mm.
That prolapsing tissue can cause the urethral meatus, the opening, to retract both anteriorly and posteriorly.
Oh, wow. So it just hides it.
Basically, yeah.
Yeah.
It hides it from direct visualization entirely.
It's like trying to thread a rope through a kinked garden hose, or, trying to find a hidden tunnel entrance when the whole landscape has just collapsed over it.
That is a perfect analogy.
Mm.
And the immediate danger is that natural human instinct to just push a little harder when you meet resistance.
Which the sources strictly warn against, like flashing red lights. Never force the catheter.
Never. Because the internal lining of the female urethra isn't a smooth pipe. It's lined with these delicate epithelial folds.
Like little overlapping ribbons, right?
Right. And they are highly prone to trauma. If you try to force a rigid tube past that sharp anatomical kink, the tip will catch right on those folds.
And that causes a false passage.
Exactly. You tear right through the mucosa and create a new traumatic tunnel. It causes severe bleeding, high risk of infection, and you still haven't even reached the bladder.
Which is just a catastrophic clinical outcome. So here's where it gets really interesting. Now that we understand the physical kink caused by the prolapse, how do they safely navigate it?
This is where the tactical workaround comes in.
Yeah, the finger guide technique. The sources detail this step-by-step procedure. Obviously, it starts with positioning, getting the patient in a supine, lithotomy, or frog-legged position to maximize exposure.
But if the meatus is hidden or kinked, just looking at it won't help.
Right. The clinician literally has to physically recreate the normal anatomy. The sources say they place the index finger and sometimes middle finger of their non-sterile hand just inside the vaginal orifice.
And then they apply this gentle but firm upward pressure against the anterior vaginal wall.
Yeah.
If we connect this to the bigger picture, this specific physical movement is doing two major things mechanically.
It's lifting everything back up.
Exactly. First, it reduces the prolapse by literally pushing the descended bladder and tissue back into its proper place in the pelvis.
It's like temporarily acting as the pelvic floor.
Right. And second, that upward pressure straightens out the kinked urethra. You eliminate that sharp inferior angulation.
And that tension actually forces the opening back out of hiding, right?
Yeah, the meiaca can then be felt.
Mm-hmm.
The sources describe it as feeling like a distinct buttonhole on the anterior midline.
The buttonhole, right.
So once they feel that fibromuscular ring, that non-sterile finger basically acts as a physical guide rail for the catheter.
You just slide it right over the finger. Well, wait, I want to push back on something here. If the anatomy is that delicate and it's retracted and distorted, shouldn't the clinician use like the softest, largest catheter available just to be as gentle as possible?
You know, it's funny you say that because that is a very common assumption.
Mm.
But the clinical evidence absolutely corrects that.
Really? Why?
In cases with a stenosed or retracted meatus, utilizing a soft latex catheter is actually a recipe for failure.
Oh,
A smaller, firmer catheter, usually made of silicone or vinyl, is highly recommended.
okay, that feels counterintuitive.
It does, but it comes down to column strength. A soft catheter will simply buckle against the distorted tissue. The moment it meets resistance, it just folds over on itself.
Oh, I see. It just bunches up.
Exactly, whereas a
Okay.
firmer catheter holds its shape. Or they might use a coude tip, which has a semi-rigid curved tip to navigate those anomalies.
So you need something rigid enough to actually ride that newly aligned pathway that your finger just created.
Yes, you stabilize the environment with your hand, and you use a firm tool to navigate it.
That makes total sense. But successfully navigating the urethra is really only the first half of the procedure, right?
Right, getting to the bladder is just part one.
Because this catheter is being placed to drain the bladder or, instill therapies, it has to be perfectly secured without causing internal injury. And the sources outline some really strict protocols for anchoring the Foley catheter.
The anchoring mechanism is the balloon at the tip, and the rules around inflating it are non-negotiable, starting with insertion depth.
Yeah, let's talk about the insertion depth rules. Because the female urethra is so short, the clinician has to advance the catheter 3 to 5 centimeters after they see urine flowing.
That is a critical point. A lot of people might think, oh, I see urine, I'm in the bladder, time to inflate.
But that's dangerous, right?
Incredibly dangerous. The drainage eyes, the holes where the urine enters, are at the very tip, but the balloon is located just behind those eyes.
So if you stop the second you see urine.
The balloon is still sitting inside that delicate urethra. If you inflate it there, you subject those epithelial folds to massive hydraulic pressure.
Oh man, that sounds painful.
It causes severe trauma, permanent strictures, massive hemorrhage, even complete rupture.
Wow. So advancing it that extra 3 to 5 centimeters guarantees the balloon is floating fully inside the empty space of the bladder.
Exactly, not resting in the urethra.
Okay, so once it's safely in there, there are strict rules about the fluid used to inflate it. The sources note that you have to inject an entire 10 cc syringe of sterile water to completely inflate a 5 cc balloon.
Yeah, and that discrepancy confuses a lot of people. Why 10 cc for a 5 cc balloon?
Right, it seems like it would pop.
It won't. It's because of the internal dead space. The catheter has a microscopic channel running its entire length just to deliver that fluid.
So the 5 cc label on the package only accounts for the balloon itself.
Right, you have to fill that whole pipeline before any fluid actually reaches the balloon.
And if you only inject 5 cc total,
You end up with a partially filled balloon, which is incredibly dangerous.
because it can slip out.
Yeah, it lacks the spherical geometry to anchor properly. It can migrate down into the urethral opening, cause continuous irritation, or just get accidentally dislodged.
So you have to put in the full 10 cc to make it taut and secure. And another thing the sources mentioned that I found surprising is about pre-inflating the balloon.
Oh, to test it.
Yeah. I mean, it seems like common sense to test the equipment before you put it inside a patient, right?
It does, but it is explicitly not recommended, especially for these firm silicone catheters.
Because it ruins the smooth profile of the balloon.
Exactly. When it's made at the factory, it is perfectly smooth. If you inflate it on the sterile field and deflate it, silicone doesn't have the memory to go back to that factory state.
It gets all wrinkled.
Right. And those microscopic ridges increase the surface friction. You're already trying to navigate a delicate, distorted urethra, and now you're dragging a textured, wrinkly object through it.
Making a hard insertion even harder. You just have to trust the manufacturing.
You do.
Okay, but I want to ask about the fluid itself. The sources say you have to use sterile water. Exclusively. Why not just use normal saline or air? I mean, it's in a sealed balloon. It doesn't touch the patient's internal tissue. It seems like kind of an arbitrary rule.
What's fascinating here is that it's all about pure chemistry and fluid dynamics.
Yeah.
Saline should never be used because of the microenvironment.
Because of the salt.
Yeah. Normal saline has dissolved sodium chloride. When you put that into a body operating at 37 degrees Celsius for hours or days, the water slightly evaporates through the silicone.
Oh, wow. So the concentration changes.
Right. And the salt actually precipitates out of the solution. It crystallizes.
You literally get salt crystals forming inside that tiny delivery channel.
Yes. And they migrate straight to the deflation valve and permanently jam it shut.
Oh my gosh. So when you try to take the catheter out?
You can't. The valve is cemented shut, and the balloon is fully inflated inside the bladder. You have to use ultrasound to manually puncture the balloon with a needle through the abdomen just to get it out.
That is a nightmare scenario just from using the wrong water.
It really is. So no saline.
Okay, but what about air? Air doesn't crystallize.
It doesn't, but air is buoyant. If you fill that balloon with 10 cf of air, it acts exactly like a buoy. It floats to the very top of the fluid-filled bladder.
Oh, I see. And gravity means the urine is pooling at the bottom.
Exactly. The drainage eyes are right next to the balloon. If the balloon floats to the top, it drags the drainage eyes up into the empty space.
So it's not even draining the urine at the bladder neck. Plus, I imagine a floating balloon tethered to a tube could cause it to kink.
It does. It can cause the catheter shaft to fold over on itself inside the bladder, completely blocking the line.
Wow. So what does this all mean?
It means that placing this device isn't just about manual dexterity.
No, it really is this intense, perfect blend of anatomical manipulation and strict adherence to, like, fluid dynamics and material rules.
The clinician has to be an anatomist, a material scientist, and a physicist all at once.
Yeah, it's essentially structural problem solving. Rebuilding that anatomical landscape, using the finger guide technique, selecting the firm catheter to bypass the prolapse, and precisely anchoring it with sterile water.
It really shows an incredible respect for the unseen mechanisms of the body.
It totally does.
But, analyzing this entire intricate manual process,
Yeah.
this raises an important question for us to kind of mull over.
Okay, what's that?
Well, we've just detailed the intense biomechanical acrobatics a clinician has to perform to safely insert this rigid tube into a shifted environment, right?
Right.
But conditions that alter the pelvic floor like childbirth, weight gain, menopause, they are incredibly common. They aren't rare anomalies.
No, millions of patients deal with this.
Exactly. So given how universal these shifting internal landscapes are, why hasn't fundamental catheter design evolved to dynamically adapt to them?
Oh, that's a really good point.
Right. Why in modern medicine does success still rely so heavily on a clinician's manual dexterity and forcing a static, rigid tube into a dynamic, compromised space?
Why are we rebuilding the patient to fit the tool instead of making a tool that fits the patient?
Exactly. Perhaps the next great leap isn't refining how we insert it, but completely reimagining the tool itself.
That is a highly provocative thought to end on. It's so true. The variables of the human body are always shifting, and our technology really needs to keep up.
Absolutely.
Well, thank you so much to everyone listening for joining us on this deep dive into the hidden mechanics of everyday medical procedures. We hope you keep questioning the systems behind the science.
See you next time.
Take care.